Assalamu alaikum, everyone. So this is a case of a 57-year-old lady, APS of 90, who presented to us with a complaint of headache, vertigo, and tremors for nearly 6 months. Moving to the MRI scan, it shows a right cerebellar paravermian contrast enhancing lesion.
So Yusuf, this Dr. Shumaila can give some input now. Right.
Okay, sir.
So there is a T1 hypointense lesion in right paraventricular region adjacent to fourth ventricle in right cerebellar hemisphere, and it is showing post-contrast enhancement. If we zoom in these images and look at the enhancement pattern, it seems that there is some medial nodularity along with some kind of a cystic component, and there is, I don't have any T2 in this, so if you can show me the T2 weighted images and flare.
Sure.
So if we look at the coronal flare and axial T2 weighted images, there is some perilesional edema and some mass effect on the right medial wall of fourth ventricle. But still there is no ascending tentorial herniation. There is not a lot of mass effect, so it seems to be, and there is a solitary lesion, so it seems to be a neoplastic lesion, not very aggressive. I will grade it as intermediate to low grade glioma, and that's all. Yeah.
Yes, Yusuf.
So following this MRI scan, and patient underwent suboccipital craniotomy and near total resection of the lesion. There was mild residual disease. Moving to the MRI post-op scans, please.
डॉक्टर शुमाइला, आप पोस्ट ऑप स्कैन्स को थोड़ा सा
So what is the time interval after surgery when these scans were performed? How many weeks after surgery?
Ma'am, within a day, within 2 days.
No, I think Yusuf, you sure about that?
Yes, sir. देखिए surgery November 9th को ही है, post-op MRI भी उसी दिन का होगा.
Okay. So usually we get these scans done within 24 hours.
Yes. So that is why I just wanted to check the optimization of time. So in the surgical bed, there is some enhancing residual component, which is visible, and there is like some 80% of the tumor is resected, but there is still some enhancing component, although there are some flow artifacts in this region as well. But still we can appreciate that there is some enhancing component in this region.
Okay. Here also we see some.
Yes, it is seen here as well that there is reduction in volume, but still there is some residual enhancing component present in the surgical bed. Same findings redemonstrated.
Right. So, okay, we have Dr. Shayan also. Dr. Shayan, do you want to add something?
Assalamu alaikum. Yes, sorry, I missed the initial presentation, but I have seen this case previously. So, like on imaging, we see that this is a kind of well-circumscribed lesion, which is hyperintense, and we see very less vasogenic edema associated with it, and then we see some heterogeneous nodular enhancement within the tumor. So it is not very nodular peripheral as we see in high-grade tumors. It's more like central enhancement, nodular enhancement, and intense enhancement. So based on these features, the findings raise differential of a glioma, which can be of low-grade type, or a lymphoma.
Okay, thank you. So the histopath was pilocytic, right, Yusuf?
Yes, sir. It was pilocytic, but there was a bit of confusion initially because it showed a bit of atypical features, but eventually it was finalized as pilocytic astrocytoma.
Okay, Dr. Mazhar. So now we come to you. So
I feel like there is some enhancement left there, so I would prefer to radiate this patient rather than leave it for a recurrence.
okay, okay. I think we have Dr. Asim also. Dr. Asim, can you please share your opinion? Okay, I think. Okay. Dr. Altaf, what do you think? Dr. Altaf is also here with us.
Yes, Asan, thank you very much. I think in this particular case, it's a low-grade glioma and the significant portion of the tumor has been resected.
Okay.
The wait and watch policy with the surveillance MRI at 3 months, and if disease is static, then continue to follow it up with the surveillance MRI at 3 and then 6 months would be advisable from my opinion. However, the radiation oncologist input is always important in this case. If Dr. Mazhar is radiation oncologist and he thinks that he can radiate, then we can discuss it with the family. However,
Right.
observation with surveillance is also a valid option in this case.
Okay. Dr. Mazhar, when do you opt for, like surveillance if there is some minimal residual left in the low-grade glioma, and when you opt for the radiation? How do you? Yes, please.
Actually, when the radiologist after surgery feels that there is just a cavity and there is hardly any tumor, so in that case I would follow it up. But here the radiologist said that there is enhancement.
Yep. Yeah. Right. Right. So if there is enhancing part left, you will opt for radiation. That's what I
I will
understand.
opt for it because sometimes our patients are lost for follow-up and they come back again with
Okay.
yeah. So
Yeah.
just to be on the safe side, most patients are not very compliant and they come out from far off area in our center and
Right.
from.
That
So
makes sense.
I radiate them if the radiologist feels that there is some component still there.
Okay. Okay. We have Dr. Riaz Raja also. So Dr. Riaz, we can have your opinion. What do you think if it was like a pilocytic astrocytoma, then there is minimal residual left?
Okay,
So
I think pilocytic astrocytoma is a benign lesion in the glioma series, so better to watch. Or everybody has his own opinion. I
Yep.
think to me, I will suggest to observe and repeat MRI in a period of time.
Okay, I think what Dr. Mazhar mentioned is a very valid point from LMIC point of view. Sometimes, if the patient has a very good follow-up, maybe, but what he was
Yeah,
saying,
then you can follow it up. But if the patient, most of our patients, the problem with them is we call them after 3 months for MRI, they will not come. Then after a year or something, they will land up with headache and vomiting, and like in different tumors, the same story. Like the compliance is so important. If it's the low grade tumor, if this patient is compliant, educated, one can follow it up as well. I mean, it's plus my. I mean, one can
right,
follow it up. But in case if you feel that this patient can be lost, then I would radiate, and if he doesn't come after that, that's fine.
right.
I have one question with Dr. Mazhar. So is there any complication, minimum complication of the radiation to the patients, particularly like in this case?
Actually, this is a very small area, and the dose that I would give it would be within the tolerance of most of the organs, brain components there. So in this case, I would recommend 54 gray and 30 fraction, 180 centigrade per day, very limited to tight fields. So he shouldn't have problems from it, because in high grade we go up to 60 gray. and with a dose of 200 centigrade per day, along with chemotherapy and all that. So those patients, when they survive, they are pretty okay. So with my dose, what I am recommending is 5,400 centigrade, 180 centigrade per day, very tight fields. So in this area, they shouldn't have much problems from that, hopefully.
That is a conventional radiation, or not the gamma knife or the saber knife?
No, because there is no data, big data to treat primary brain tumors with SRS or gamma knife until unless there is a recurrence. Normally, most of the data in SRS and gamma knife and cyber knife is in metastatic brain tumors. So most of the primary brain tumors, we don't offer gamma knife.
Yeah. Great.
That's interesting.
It's not that one cannot treat it. One can treat it, but there isn't much data about it because most of the tumors are pretty big and the cavities are pretty big. So the dose in SRS and gamma knife is a very, very high dose. So if the cavity is big, then the chances of side effects and necrosis and all that increases.
But we haven't seen such type of the immediate or the little bit late post radiation complications in cases of the SRS and the gamma knife. Because personally, I see the patients who has been irradiated with the gamma knife, so they don't have the particularly I've seen up to the 1 or 2 years, but they don't have the such type of complications, only the headache and the nausea. But I don't know, and I can't comment about the long-term side effects.
Yeah, but actually, it depends on the cavity. If the cavity is big, then the size of the tumor and the cavity, if that is big, then the side effects can be more. If it's a small area, then the side effects are minimal.
Yep. I have seen a couple of patients after stereotactic, cystic formation, and some couple of patients I saw there was more mass effect also, but not many. I just talked to Dr. Altaf. You were saying something.
I was just kind of giving an opinion about the SRS and gamma knife, because recently in meetings, our gamma knife people have been discussing a lot about radiation to the primary brain tumors. And Dr. Mazhar is saying the effect which is contrary to their discussion, but it's an interesting fact. Let's see what the future paper are coming out of a developed world where the gamma knife has been developed.
I think what Dr. Mazhar said is a very valid point. For anything, we need to have high quality studies and we need to have data. Before that, everything is an assumption, and it's like your own personal experience. Yes, you're right. But yeah, maybe it shows a good result, maybe it would not. So unless we have that evidence, we will not have our conclusion. Dr. Fatma, you have worked on our guidelines. Do you want to add something? So Dr. Fatma is our surgical oncology fellow here, and yeah.
Thank you, Dr. Hassan. I think it's very interesting and very valid discussion, because I have the same experience. I have seen a couple of patients, especially with small temporal ganglioma, and they underwent gamma knife, and then there's significant progression. And I think that has prolonged their illness. And definitely, if we don't have the evidence, I think this should not be our standard of practice, unless we have our own case series and then we have our own data.
Right. True. Okay, we can go to the for this case. So we are saying that if we can follow up the patient and if patient can be compliant, then we can watch. Otherwise, it's better to opt for the radiation. Yeah. So we need to have this discussion with the patient and pros and cons and everything. So the risk of the progression of the disease.